I'm Michelle Lazarus. I'm from Monash University, and I've had some great conversations around the topic of tolerance of ambiguity, which is where my research happens to be focused right now. So tolerance of ambiguity is a misnomer because I think many people think of it as sitting in a garden, as I described at my talk, being zen about all the ambiguities within the healthcare environment. But in reality, it's being able to make a decision despite ambiguities in the healthcare environment. So patients present differently, their treatments may react differently with their bodies, and their outcomes may vary across that issue. So a doctor has to manage all of these ambiguities along with their own tolerance, their own acceptance of ambiguities within this environment, and we're trying to understand and explore what tolerance of ambiguity is. And what we're starting to realize is it's incredibly complex, and the feedback and the conversations I've been having is that almost everybody that I've talked to has experienced the ambiguities in healthcare and think it's a valuable and important area to research.
I'm Rebecca Stewart. I'm from Townsville in North Queensland. I'm a GP and I'm a fellow of ANZAHPE. And the session I really enjoyed was this final session I just attended. It was a bit of an eclectic mix. It was called the Other section. But interestingly, all the presentations segued into each other in some way, and particularly the last presentation, which was on humanity in education, was really inspiring.
G'day, so my name's James Padley. I'm I wonder what I am now after attending the plenary about clinician educators. So I've been a doctor for about 9 years and recently joined academia in teaching capacity. I thought it was a great plenary. I took away the fact that it's still, we're early in the game of how we train educators. And the major thing I took out of it was how we can reinforce teaching theories and what's best for students and junior doctors, and trying to teach that to clinicians who are out there doing the work. So yeah, I'll take some of those lessons back to university and see what we can do.
My name is Dr. Sharon Darlington from the University of Queensland. I've just facilitated a Pearl session, which is a personally arranged learning session which are unique to ANZAHPE, and it's a great opportunity for us to come and present a dilemma that we're having and really mine the wisdom in the room to see what solutions others might have come up with. So our topic was "The lecture is dead, long live the lecture," just looking at the challenges of using traditional lectures, the technological drivers away from that, student expectations, pedagogical reasons, and essentially my take-homes were that virtually every other institution represented here were all struggling with the same thing, perhaps only 10% live attendance at lectures, students wanting to have all sorts of flexibility, and the exponential growth in technology options for delivering lectures. It was really encouraging to hear some suggestions of unis where they've completely cancelled lectures, they're using podcasts instead. Others were using a lot of flipped classroom. So in some ways, similar dilemmas, similar solutions. I think everyone enjoyed engaging and hearing some ideas from others. So.
Hi, I'm Roy from James Cook University. I've just attended the session on Long Live the Lecture, which was really exciting. It was a Pearl session. We discussed about the old format of lectures and how many people think that it's possibly a dead format, but it's still obviously being used throughout many universities, we found from discussions today. But many alternatives are being used, including podcasts, videocasts, and many other blending learning modalities. I found it a really good session, and I took a lot from it, which I hope to relay back to my colleagues at the university.
Hello, my name is Alexandra Webb. I'm from the Australian National University Medical School, and I have just presented a workshop on incorporating technology-enhanced learning to improve interactivity in your classroom. Technology is a great way to introduce interactive learning to your educational environment. I particularly love the use of technology to encourage students to do regular practice testing with feedback, which really encourages them to develop optimal learning methods.
Hi, I'm Sharon Darlington from Deakin University School of Medicine. I went to a session today by Professor Brian Jolly from Newcastle University on faculty development and organisational change. The highlight for me from this session was hearing Brian speak. He's an excellent presenter, but also considering when we undertake faculty development that we need to make sure that we prepare the organisation for the work done by the faculty development. Otherwise, we work on training individuals to teach better in the university or hospital environment. However, when they go back to their work environment, they actually find that they can't use the skills that they're taught because the organisation isn't prepared. So we really need to make the organisation aware that they'll be bringing back new knowledge, and it's very valuable knowledge, and this is how it can contribute, and their knowledge will align with the organisational values. Thank you.
I'm Adrian Stewart of Flinders University, and I was just part of a team that delivered a symposium on complexity and how complexity relates to and underpins basically the practices what we do as a clinical educator. So the team was with Kosila Kumar and Priya from Sydney University and Gillian Nisbet. And I think the important thing is that we know a lot about the theory and complexity theory, but we don't quite understand how it basically translates to practice, clinical practice as an educator. And of course we like to have everything linear, things need to be predictable, and in complexity theory and working also in complex adaptive systems and preparing students for that, nothing is linear. So I think we have to get used to that and accept a little bit of chaos and also that the context can be very specific to what we need to keep in mind as a clinical educator.